to be hearing about traumatic brain injury. So we are very, very fortunate. I'm going to go ahead and introduce our speaker and then kind of go over the plan for the evening, and then we'll get going. So we are very fortunate to have Dr. Jennifer Erickson, who's a psychiatrist who also has board certifications in CL, neuropsychiatry, and brain injury medicine. She has an interest in telehealth. She's part of several projects that included working through and around pre-pandemic rules and regulations. She is the clinical lead for the TBI Behavioral Health Echo Program and also the APD at the University of Washington Psychiatry Residency Program. So we're going to hear her talk to us about traumatic brain injury, common psychiatric sequelae, everything under the sun, a little bit of everything. So after that, we'll have a question and answer time frame. So we do have a few questions that have come in already when people registered. But also, as we go along during the presentation, if you have questions you'd like to ask at the end, please feel free to drop them in the chat. We're not going to do questions during the presentation itself, but if they're in the chat, then they'll be there for when we get to the Q&A part at the end. Or if you prefer to wait and ask your question verbally, we'll ask people to use the raise hand feature on Zoom so that we can make sure everyone's not trying to talk at the same time. So that'll basically be our layout for tonight. So without further ado, Dr. Erickson.
Thank you for the gracious introduction. And hello, everyone. I am on a slightly different time zone, so if I make a reference to a time and you look at your clock and think I'm not telling the truth, I am. I'm just on Pacific Standard Time. So fair warning, I will do my best to get it correct. Sometimes I don't. I'm going to be talking about TBI and behavioral health, and just a little background about me. I became really interested in this topic during residency, partly because I went to residency in University of New Mexico, and it is one of those glorious states that has everything under the sun for outdoor activity. And I was seeing a lot of patients come through who had brain injuries and had behavioral health issues. Specifically, they had behavioral health issues, and then, as young people do, decided to climb, jump over, go under something, and ended up injuring their head. And it just really changed my perspective on needing to know more about that. So with that in mind, we'll get going. This is me with shorter hair. Here are our learning objectives. We're going to talk about the neuropsychiatric conditions. I use the term neuropsychiatric because there is probably a foot in both. Some people will stretch that term even in the neuropsychiatry, behavioral neurology, to include almost everything, including depression, because likely there is a neurologic basis to some of those things. We're going to talk about some opportunities for pharmacotherapy treatment and just kind of some boundaries with that, and also talk about monitoring and potential side effects. As I was saying, in residency, I learned a lot as a result of needing to learn a lot about brain injury. And this is one of the things that are some of my take-homes. We're going to spend a few minutes talking about TBI. Everyone here, I understand, is psychiatrically trained and knows all of the good diagnoses and knows psychiatry. That doesn't necessarily mean all of us remember some of the things about neurology. And I noticed that one of the things that you looked at a few weeks ago was actually dementia. And I'm sure a lot of you learned that there's some big changes coming to how we think about dementia, especially from a research side. So big picture, not every head injury that happens is a brain injury. And you definitely see this in trauma centers. People can break their jaws, which is part of their head. People can injure an eye. That doesn't mean that's a brain injury. And we'll look at the criteria in a second for what traumatic brain injury is, but not every head injury is an injury to the brain. Acquired brain injury is a big bucket term that includes all brain injuries. The reason this matters is that different brain injuries, different etiologies potentially have different rehab and recovery implications. And for us, potentially different things we need to do. Example of an acquired brain injury would be a stroke, for example. A hypoxic ischemic injury is technically an acquired brain injury. It is not, however, traumatic brain injury. A lot of the original research and things that we extrapolated about managing traumatic brain injury and behavioral health concerns after it was actually from strokes. And so as we've gotten more research and literature, it's been clear that those are technically different things. Also, the recovery of these things are different. When someone has a stroke, The potential for them to recover after a certain period of time, up to a year, may not be as robust as someone who just had a traumatic brain injury. Brain injury can change over time. And this is really important when we think about medications, is that sometimes things that we treat people with at 3 months after an injury or 6 months may not be what they need at 15 months or 16 months. Realize that time gap wasn't dramatic. The other thing I want to point out as a big bucket is that in general, as we move up the severity of a brain injury, you're more likely to get more injuries. So in the outpatient setting, if I have someone who's had a severe TBI, it's very likely that they have some other mobility issue. It's possible that they have some other endocrine issue or headaches or pain. And this sometimes makes it harder for them to interact, as in make outpatient appointments, come to see us, or it leads to other potential medication side effects I need to be watching for. So more severe does matter. The other thing, just in general, from a behavioral health perspective, there is very good evidence that it doesn't matter from mild to severe. All of these different severities of TBI can result in mental health complications. In fact, there are certain things that are more likely to happen in mild TBI than severe that we'll highlight. So there's a whole gamut there. Brain injuries, and I'm sure I have a captive audience about this, they matter. They definitely matter, and especially traumatic brain injuries. This is kind of just overview of what we can think of when we think about traumatic brain injury. These are the things that can happen. Motor vehicle accidents often being most common depending on the age gap, assaults, falls, sports related, gunshot wounds, blast injuries. The reason I bring them up is that all of them potentially can tie to a psychological, it can have a psychological impact beyond the injury itself, and can lead to other things that we may need to treat. Anytime I'm dealing with someone who comes in with a history of TBI, I know that that's probably not just a physical trauma, but there's likely emotional trauma, and I need to probably suss around a little bit to see if there's any avoidance going on with some of those returns or concerns. There's my pretty graph showing the same thing. Most common reason is falls. People fall down. And that tends to be true mostly, regardless of age. Looking at TBI severity, again, digging into this before we talk about the neuropsychiatric stuff that comes up. These are the general scale. Depending on the healthcare system you work in, i.e. if you're in the VA or Europe, there'll be some tweaks to the scale, as in did someone throw up? But for the most part, for right now, if someone has normal neuroimaging and they lost consciousness or had a change in their neurostatus, slash were confused, had post-traumatic amnesia, i.e. don't recall what happened, and have Glasgow Coma Scale findings, it's very likely that they had a TBI. The length of it matters. There's a little bit of discussion in the literature about trying to unify all the definitions, especially in the brain injury medicine world, because you can imagine specifically, there may not necessarily be a significant difference from someone for someone who lost consciousness for, say, 30 minutes as opposed to 31 minutes. But generally, when I'm talking to someone and evaluating them, this is what I'm trying to pull out. Did these things happen? And specifically, was there a specific event? Was there loss of consciousness? Do they recall all those things? And the other tag on this is, how do they know that information? Were they told or do they remember? Because there's just some nuances you have to kind of look for there. Tying this directly to the brain, as I mentioned, not every head injury is a brain injury, but this is the pattern we see with traumatic brain injury that is non-penetrating. There are three major types of brain injuries that we think about right now. One is non-penetrating, as in it's an impact and the brain will hit the skull itself. One being penetrating. The classic thing that we all learn about is Phineas Gage with the tamping iron going through his front orbit and changing his personality. That would be an example of a penetrating injury. For those who work in trauma centers, you definitely see penetrating injuries. The third type is a blast injury, which is considered something that is pretty rare outside of military settings, although theoretically possible. It has more of a punctate, crossed, almost like micro bleed pattern. It's a little harder to capture neatly with colors on a nice little MRI/computer generated brain. But looking at non-penetrating injuries, and what we know about the overlap between psychiatry and neuroanatomy, there are three big areas that are affected in traumatic brain injury. One, the cortex itself can be impacted by subdural hemorrhage. And you can see things like changes in motor function, weird misidentification syndromes, all sorts of stuff if you put enough pressure on the cortex itself. Too much pressure and we end up with herniation problems. That's a whole other talk entirely. The other areas that are really interesting and are pretty commonly affected are, as you can see, the frontal poles, temporal poles, the occipital pole, and then part of the cerebellum. The reason these are very, very interesting is often these are tied very directly to psychiatric disorders, as best we can figure out. I realize the models are evolving still. But the frontal lobes are tied to depression, OCD, anxiety a little bit, not as much as the temporal poles, but mania. The temporal poles can be anxiety, impulse control disorders, memory problems. The occipital pole, most people who end up with a TBI, especially a severe TBI, often moderate, have visual processing things. So sometimes they'll be describing headaches and trouble concentrating because their eyes don't actually work the same as they did before. Same thing with balance issues of the cerebellum. That nice midline cross section shows another injury that can happen. In general, most people aren't going to hit straight on the front or back of their head. And that might be me just talking about how I fall. Especially motor vehicle accidents, there tends to be someone hit from the side, and that rotational component can lead to what's known as diffuse axonal injury. Axons sometimes have a little give and are a little forgiving going this way. They're not as forgiving going that way. And that can lead to diffuse injury of a variety of things. Specifically, you'll see the areas that are highlighted. They can lead to emotional disruption. There is that highlight of the thalamus and the hypothalamus there really suggests the possibility of endocrine disorders, which can happen. If someone's telling you and saying that they're losing their eyebrows, say 8 months after a TBI, it might be worth having a primary care doctor look at that. And endocrine disorders are very common. So lots of areas of the brain and lots of things that we know to be tied to psychiatric disorders. One of the things that happens as we've now studied it is that we can see that one, there are lots of areas of the brain tied to psychiatric disorders, and two, there's actually an increased prevalence that stays relatively stable after someone's had a TBI. This graph is from a rather brilliant paper, actually, from 2021. And it actually looked at the annual prevalence of different cases of psychiatric disorders in moderate to severe TBI. Often mild TBI is pulled out. It's a little harder to get clear diagnostic evidence that is representative of that population. It's also a huge population. Most common injury is mild. But you can see 1 year, not the first, not pre-injury, but 1 year after a TBI, over 60% of patients will have some sort of diagnosable axis 1 disorder. I realize axis 1 is an old term, but what they were used and what they did during this research, but over 60%. And that steadily declines, but even 5 years out where they ended the study, still almost 50% of patients have something that's diagnosable psychiatric. And it varies. I mean, uncommon things being eating disorders, somatoform disorders, adjustment disorders, and psychotic disorders, but things that we see that have real implications like mood disorders. I mean, the others do as well, but mood disorders have a big impact. We'll talk about depression in a second. Anxiety disorders have a huge impact. And substance use disorders, which I don't spend a whole lot of time talking about in this because that's a whole topic in and of itself, hours in the making, quite frankly, are an independent risk factor of getting a TBI. So the risk of relapse and potentially re-engaging in non-productive substance use disorder activities makes you more at risk of having another TBI. So a lot of challenges with this. i.e., if you're seeing all of these patients who may have had a TBI who seem to also have psychiatric symptoms, there's a reason. And it's because the two overlap and they do interact. I'm going to spend the rest of our time kind of marching through these neuropsychiatric sequelae: depression, mania, anxiety, psychosis, cognitive impairment, which I think I got a couple of questions about cognitive impairment, aggression, and insomnia, as kind of the targets that we'll talk about. Again, all of these could be topics in and of themselves, but high level to give everyone some tools. And just to kind of scope it down, brain's complicated. I realize it's a silly term, but it is. Brain's complicated, and what the brain does is sometimes complicated, but as lean as possible. So with that, I also want to talk about neuropsychiatric treatment. I know a lot of you are doing this already, but just kind of our northern light, our northern star, as we talk about TBI and TBI treatment. I often get patients referred in the outpatient and inpatient setting because people say TBI and they're like, I don't know which is which, the TBI or not. I don't know where to start. What do I do? And this is always what I go back to. Some of it seems kind of basic, but going back to a biopsychosocial approach is really, really important. Most of the time, there was a person who probably had some struggles or, was at a phase in their life that had a brain injury. What were they like before? Who were they like before? What were the people and support in their life before? Now that they've had the injury, how has that changed? Are there things that we need to modify in the environment? Really, really important looking at all of those things. It'll also tell you if there are hints of psychiatric disorders we'll talk about again later, because there are certain diagnoses that are more likely to make not the best decisions, and as a population end up getting more TBIs. So are there hints there? One of the other guiding lights with TBI is that we want to maximize as best we can with as few medications as possible. I mentioned with severe TBI, you're likely to have other injuries and other things going on. Those med-med interactions and the lists I often see are really complicated really quickly. And so anything we can do, especially in the mental health realm, to decrease the number of meds someone's on is important. The other thing, which I don't have a slide on, but just as another guiding principle, patients typically, their brains do change over time. They're recovering from an injury, and our job is, one, to get out of the way as best we can, as safely as we can, and two, what they may need at 1 year from a medication standpoint to sleep, to do all these things, may not be what they need at 2 years. And so revisiting the meds frequently is really, really important. There's evidence that suggests patients have more sensitivity to side effects in general if they're medically complicated and as a TBI, all the things that we think of. The other problem that comes up with TBI patients are the next two bullets, which will get me to the big banner in the middle. In spite of being more sensitive, for TBI in particular, and in general, most patients need maximum doses. And the therapeutic onset is delayed because the brain is working a little different. We don't necessarily know why these things are, but this is definitely a trend. So these are patients where a little bit of holding that truth of things will get better over time, holding that hope for them can be really important. Making sure they know that we all know the party line, 4 to 6 weeks at minimum for any sort of response for most patients. It may be closer to 8 for them, 8 to 10. And so having that education point for families and for patients is really, really important. Hence the middle maxim of start low because they may have side effects, go slow because they may have side effects, but you do need to actually go and hold kind of that hope. Some medications lower seizure thresholds, some medication, result in cognitive slowing. And then in spite of all this information, I had mentioned that a lot of the data that we use for TBI was extrapolated from strokes. We're getting a little bit more, but there's still very few randomized controlled trials that exist. And so a lot of the data we extrapolate from other neuropsychiatric disorders and what we do for the general population. And I just want to point out in general, with very few exceptions, all of the tools that you typically use to treat patients who have depression are mostly still, or any other neuropsychiatric disorder, are mostly still in that toolbox for you to treat. Don't feel so shy. And I suspect you all aren't, but I definitely run into this problem where people will, providers will be afraid to do anything. And I'm like, actually, there are some things we can do and are well within our realm. Okay, switching. There's another hallmark sign to say polypharmacy is common. There's also a lot of common comorbidities I've hinted at, including anxiety, panic, very common. As we know, comorbidities in psychiatry are just kind of expected. I actually rarely see people, especially in the university setting, that have one thing, but lots of comorbidities with TBI, and keeping a hand on them is important because it's very likely there is more than just depression, anxiety, or fatigue going on, sometimes all of them. And just a highlight of why we're doing this, again, I think one of the more troubling things that happens with polypharmacy is we can potentially have people fall more. There are lots of reasons, but preventing another TBI is often what I work on. As a reminder, and I know all of you know this, preventing polypharmacy, there are lots of clever things we can do, especially if we're working on trying to clean up someone's med regimen. And in TBI, since all of these things, anxiety, it should say depression, not sure why I got cut off, insomnia, pain, irritability, fatigue, if people have more than one of those, matching and thinking about meds and decreasing other meds important. I think I've hit on this hard enough. So we're going to switch and actually talk about some of those neuropsychiatric disorders I had mentioned. So first, depression or / apathy. As we all know, different things. The prevalence of major depressive disorder, as in actually the disorder diagnosable as it is 44.3%. This was a study done in 2000, and this is actually probably a very conservative study. It's one of the larger populations, which is why I continue to cite it, even though it's now 24 years old, which is terrifying to say out loud, but it is. One of the two big things pre-injury, and why I said biopsychosocial is important, is making sure that we're assessing for pre-injury depression, and also alcohol use, substance use, very, very common as one of the things that comes up. Depression is something that can appear in the acute setting and the rehab setting, in the post-acute setting, as in they were just discharged, now they have a new depressive disorder. It came out of left field, but it's here now, or even chronically. You can see it appear late as well. One of the big keys with depression is that it doesn't correlate to TBI severity. As in, you can have a mild TBI or you can have a severe TBI, and you can still get depressed either way. Yeah, I'll definitely hear this as a myth I end up busting with a lot of people. The same is true. You can have a severe TBI and never get depression. And so making sure we're vigilant for that. Apathy alone, as in disinterested, disengaged, lack of motivation, that alone has a prevalence of about 10%. And often this is the things people's families will bring them in. And you can imagine there are some things you can do with apathy pharmacologically, but this actually becomes an education point with families and patients and figuring out how to work on that, potentially non-pharmacologically in actually either case, but especially with apathy. Just a comparison to sell this a little more, the rates of major depression compared to other chronic diseases. TBI is one of the worst when it comes to a diagnosis of major depression after a TBI. Lots of studies looking at that, followed by multiple sclerosis. Depending on the population they look at, inpatient, outpatient, severe, what type of screening, they'll find 10%. But I've, again, seen studies up to 61%. And I tend to lean a little bit more towards it's more common based upon what I see in the literature and what I see clinically. Why is treating depression worthwhile? I mean, I've talked to a bunch of psychiatrists. Treating depression is always worthwhile. Specifically in TBI, it increases the risk of TBI, and you will also see, pardon, I derailed. We are seeing more depression after TBI, partly because there's an increased incidence of TBI. We drive fast. There are motor vehicles everywhere. Things are happening. There's also decreasing death rates. We've gotten much, much better at saving people, and I suspect we'll continue to get much, much better at saving people. Estimated 2% of the population lives with TBI-related disability. Depending on your community, this can be higher or slightly lower, but typically higher. It can depression after TBI can lead to poor cognitive functioning, lower overall health status, lower poorer recovery, greater functional disability, more post-concussive symptoms. They're referred to something, there's another term you'll see in the literature for that, but more post-concussive symptoms, more anxiety, again, co-occurring disorders. And I think one of the staggering things is up to 8 times more suicide attempts and 3 to 4 times more completed suicide attempts, deaths by suicide. And those numbers are pretty staggering. This is a reminder that the PHQ-9 does exist, and it actually is what I recommend for screening people. There is a standard that was put together by a coalition from brain injury medicine that effectively said if someone's had a TBI, they need to be screened for depression once a year. Most primary care are screening everyone for depression once a year, but specifically TBI patients should be screened. PHQ-9 is the PHQ-9 is a validated scale for people who've had depression, not depression, but a TBI, and to screen for depression in post-TBI patients. You can imagine there may be some problematic components, but the things you look for are still things that are transdiagnostic symptoms. So this is again flattening the PHQ-9 into the symptoms, this get questions 1 through 9, and it's actually a comparison of MS and spinal cord injury. Those are the other things that you'll sometimes see with TBI. Slash is a fair comparison, looking at transdiagnostic symptoms. The ones in blue are ones that I always have an ear for. And anyone who works in consult liaison psychiatry, quite frankly, often has an ear for too. If someone is endorsing depressed mood, anhedonia, guilt, and thoughts of suicide or death, those are consistent with a diagnosis of depression and not with just a TBI or a medical condition. There are, again, some things that will sometimes come up with TBI. Changes in sleep, pretty common. Psychomotor changes, often common. Fatigue, especially cognitive fatigue, very common, and poor concentration, pretty common. That X migrated. It's also common in MS, in case you're wondering where that line is over 1. So someone is coming in with TBI and depression, you can still use a PHQ-9. And this is, again, what you're looking for. You can scale them. And this is actually something, there are a couple other scales that have been validated. This is the one I prefer. I go to UW. We're very collaborative care oriented, and PHQ-9 is definitely one that we use frequently. But like the STI, the HAM-D, there are a couple others that also have been validated for screening for depression and TBI. So screen. Inadequate treatment in TBI is a real problem. It's worth listening to patients and worth looking for depression post-TBI. Within the first year, less than half, almost half of patients don't receive treatment in any way, shape, or form. I think one of the reasons people are hesitant treating with an antidepressant is that the evidence isn't necessarily the most robust. There are a couple of reasons for that. 1, open label trials. 2, the way they define TBI is really messy. And 3, the length of the studies aren't necessarily great. But then again, if you look at some of the studies for antidepressants that aren't really designed well for the general population, the evidence isn't great for them either. I think the more important thing is that there isn't necessarily, for most of these things, horrific negative studies or even mildly negative studies showing that they are flat out not effective. And so it becomes a risk-benefit thing to discuss with patients. I definitely use antidepressants when I find depression in patients who are post-TBI. One of the things that's really interesting is that the study was done, and actually there's a follow-up secondary analysis of the study now that found that patients with TBI, especially our young patients, prefer counseling over antidepressants, which does, it happens, especially with some of our people who've never taken meds before. And so counseling is a viable option. The caveats to this is that often you need to know how cognitively impaired someone is. By that I mean you need to make sure that you're not giving them too much information. So this particular study, and actually the manual is, I believe, available online as part of the TBI Echo resources now. Not, it's free for the record, but there are modifications you need to do often for TBI patients, i.e., possibly shorter sessions, possibly a little less content covered. And often you need to bring in family members or create plans with family members for them to support them between. But the reality is we do that for some other patient populations too. So it's very doable. Just again, looking at treatment modality preference, this is just looking at what patients historically ask for. Physical exercise, counseling, antidepressants being the top three when thinking about treating depression, and just knowing that we can ask. Most of us are very good at that, but knowing that we can ask. I also find this study interesting because it, again, points to a generally healthy population that fell down and now is struggling with a change in both their brain functioning and their mood and wanting to return to life as much as possible. How do we treat depression and apathy? I think I hinted that there is a lot of things we can do with counseling. CBT is validated. That study I had mentioned before looked at CBT and behavioral activation, and I believe there's another follow-up study looking at behavioral activation and found that you can impact. I think the big thing is recognizing that symptoms can come back. And so you may need to do booster sessions. That's not evidence-based yet, but that's definitely what I see when I read the literature. Most of the things you see on here should all be pretty, run of the mill when you think about treating depression and apathy. The things that are in blue, not apathy at the bottom, but the sertraline and the citalopram have some evidence base. If you had to go pick something to start with and a patient was naive, citalopram and sertraline tend to be my go-tos. That said, most SSRIs are absolutely on the treatment algorithm in MAP. I use the term algorithm there like it was a thing. No, I mean, you can reach for them as you would in your normal treatment. SNRIs sometimes are a great option, especially when we think of pain. None of these should be necessarily too surprising. Newer agents have no evidence for them, but they also have no evidence against them. Neuromodulation is being used increasingly, especially in New Mexico. Lots of interesting studies looking at cognitive recovery using TMS. Still out. The jury is still out on that, for the record. And then sometimes, especially for apathy, for people who are foggy, who are really struggling, there's evidence to suggest specifically methylphenidate can be helpful in these patients, and is definitely one of my go-tos, with some boundaries, as I do when I prescribe anything that's a controlled substance. All right, just a reminder, sleep is a problem. That's one of those things that I look for and try and tailor. I'll take a moment to talk about psychostimulants. You are off-label using psychostimulants and often have to tie it to whatever insurance will cover. In your particular communities, I don't have great advice. I've definitely been asked. These are ones that have been studied: methylphenidate, dextroamphetamine, modafinil, and modafinil. Methylphenidate does have evidence for it, and it can help with a lot of things. Some of the thought behind this is I mentioned the frontal lobes in that previous slide. The frontal lobes, especially our attention and reward seeking, and our inhibition that comes with that, being able to delay, has a component of dopamine. And so the thought behind psychostimulants, especially in anger, which we'll talk about in a second, is that you're actually sort of thickening and cleaning up the brake lines so that people can sort these things. It is not surprising that a lot of these things would be used to treat ADHD, specifically with the pattern of TBI. Kind of clinically, that's what it will look like for some people. Yes, it's complicated. A lot of reasons to potentially use methylphenidate and psychostimulants for these patients, with some caveats. We're going to switch gears, move away from depression, talk about mania for a second. The prevalence of bipolar disorder after TBI is about 4.2%, which is, more frequent than our community, than what we see in the community. Some of the thought is frontal lobes, but again, bipolar doesn't necessarily fully live in the frontal lobes for most people. It's just you'll see an overlap there. One of the big things that comes up is that there's a high rate of irritability. Bipolar, a full diagnosis of bipolar is often hard to get after a TBI. Often you end up with sort of it's close diagnosis. And one of the reasons you end up treating irritability is because in a way that's like mania is because it's close and it kind of looks like it. A lot of constant reevaluation for these patients. Emotional incontinence can come up, and sometimes that can be almost tied to a bipolar diagnosis or something else we'll talk about as part of this section in a second. Anytime someone has new onset mania after a TBI, even if it's weeks later or months later, I like to make sure that they've had a good EEG. That level of behavior change, either psychosis or mania, you want to make sure there's not epileptiform activity happening because that's a very different treatment, all right, than using, say, an antipsychotic, and that may dictate which AED / what we call mood stabilizer you use. One of the other reasons I do a biopsychosocial history is that there is a lot of potential intersection with the other things we think about with mania. Genetic loading. If you have a lot of family that have mania or ADHD actually, and you have a TBI, you may be more at risk to develop mania. That may be part of what's leading there. I mentioned right hemisphere lesions, and then the other area that's sometimes mentioned is anterior subcortical atrophy. Again, not for everyone. That literature is super messy, but there are other things that come up with mania that can lead to risk factors. As a reminder, there's a lot of things that secondary mania. TBI is one of them. Some of the reasons people end up having TBIs are one of them, like medications. But there are a lot of reasons where you can end up with secondary mania. As a reminder, we're still using a lot of what we do to treat mania in the acute phase and in the chronic phase. One of the things that comes to the top, and I'll mention again in psychosis, is that you want to use second generation antipsychotics. And if you're using anticonvulsants, you'll notice that lithium is not on there. Typically, the one that has the most evidence is valproate. So that's one of the nuances I bring up. Is that this is not necessarily a patient population you want to use lithium with as a first line. Part of the reasons for that is that lithium kind of gets in the way. It can be neurotoxic. The literature is not like robust on this, but it gets potentially in the way of brain healing. And if our goal is brain healing recovery, doing everything we can to safely treat that person's behavior and get them more recovered is always, again, the goal. There are things that use in the chronic setting. Again, very familiar to most everyone. But that's the two nuances: second generation antipsychotics and valproate, not lithium. Interestingly enough, there's not necessarily a lot of studies looking at in the chronic phase using LAIs. It would be interesting. And I suspect very similar to what we see in our general manic population. I'd mentioned emotional incontinence. One of the things I will definitely see mentioned is pseudobarbituric affect, and it will be mistaken for mania by some of our primary care colleagues or some of our members in the community. Sometimes patients will come in or family members will do this. It can occur with TBI. And then this is kind of the treatment, Nuedexta. There are ways to get around it when it's on formulary, like prescribing those things separately. Moving on, touring all these things. Anxiety and anxiety related disorders are very likely to be comorbid, like they are with our general populations. And you can see all of them. All of them are slightly more prevalent after a TBI. Just calling them out. One of the nuances with post-traumatic stress disorder is that it's actually more prevalent in mild TBI than severe TBI. And while that may seem counterintuitive, often severe TBI patients don't remember the event. They will wake up later, and re-traumatization and medical trauma is very, very possible in those patients. I don't want to say that they can't develop PTSD. They absolutely can. But there's something about mild TBI and being still in that hyper-aroused state as you're coming to that makes it very possible for post-traumatic stress disorder. So much like depression, sometimes people are really traumatized even from little injuries. Little air quotes. Signs of anxiety, very, very common, very much the same as you would expect. The reason I highlight avoidance and non-adherence is often with TBI patients, that's just such a critical thing we need to address. And so just highlighting that we're watching for that. Anxiety treatment, very much the same. The one thing I will highlight is all the way at the bottom, especially with anxiety and the avoidance in the post-TBI population, really engaging caretakers is important, really engaging families and possibly talking about therapy, much like we do with everything else. But TBI, especially when someone's recovered, is almost a bit of an invisible invisible injury. I can get that out. Invisible injury. There we go. And so making sure everyone is getting psychoeducation is important. Moving on. Psychosis also has an increased rate after TBI. It is one of the least common, but it's also one of the most devastating things I have seen. What's interesting is I have child psych friends who will describe that this is what they see all the time after a TBI. That tends not to be the case in the adult population. And as a non-child psychiatrist, I'll just mention it as something I'm hearing a lot, and not something that I don't know where the literature sits with it, actually. You can have full hallucinations, full delusions, and full thought disorders. The most common form of psychosis after a TBI is actually more consistent with a delusional disorder than it is with full schizophrenia, although both are possible. It can happen immediately after a TBI or have latent onset. And I do mean much, much later onset, as highlighted in my last two bullets. The overall prevalence is just about, 1% in TBI patients, which is very similar to the general population. Again, one of the things I think is really, really interesting is that people can develop schizophrenic-like psychosis up to 20 years later. And this is one of those things that if someone has new onset psychosis, like we always do, look for seizures, make sure we're not missing something. A couple of nuances of treating psychosis, much like we were mentioning, low dose, looking to avoid neurologic insults, making sure we're doing all those things as sparingly as possible. If you are starting a med, second generation antipsychotic, top of the pile is Risperdal, or olanzapine, and then trying to avoid first generation antipsychotics. I am almost done, I promise. Cognitive impairment, very common problem, and I get a lot of questions about this. Again, TBI is an independent risk factor for increasing the risk of dementia. I've mentioned increased risk of falls a couple of times. This is part of what I think about. A single TBI is very likely increases your risk of dementia significantly. And again, lots of other psychiatric symptoms run with it. Joke break. Thinking about cognitive impairment, again, get this ask us questions, doing everything we can. If you impair, cognitive impairment may actually get better over time, over the course of years. Go-to medications are a little not necessarily robust literature-wise. Methylphenidate, again, rising to the top of things that have been studied. There is some people who've looked at non-stimulant dopamine enhancers, amantadine being the one that comes to the top of the pile. Acetylcholinesterase inhibitors are used in the literature. The evidence, again, not the most robust. Cognitive impairment is tied to depression. Treating depression will improve this patient population, for some of this patient population, I should say. And then all sorts of weird other things have been studied, looking at it, including using vasopressin. Not robust. I think one of the questions I got was, is there a treatment for cognitive impairment? And the two things that are evidence-based are, one, going back to cognitive rehab, and even a year out, you could potentially revisit. 2 years out, ask your cognitive rehabilitation providers. And then the second one is actually methylphenidate has some evidence base. Lots of things in ped recovery. I believe I have 2 more sections. Aggression can happen 70% of the time. Lots of features. This is one of those times where I engage family members, because the reality is sometimes what we need to do with this patient population isn't throw a med at it. It's actually change the environment. Lots of treating underlying etiologies, lots of behavioral interventions. One more joke break. Okay. Chronic anger issues. If things are coming up with aggression, it can look like episodic behavioral dyscontrol is often what you see. Lots of reasons for that, not just TBI. The best evidence for treating acute aggression is still antipsychotics and benzos. In the chronic setting, it's actually, and again, not robust, but beta blockers, valproate, amantadine, and believe it or not, methylphenidate, especially in the chronic setting. This should be my last section. So insomnia, ideally we treat the underlying condition, sleep hygiene again, and then all of those things that we can still use, but sparingly. If something is not working in someone who's had a TBI, it is worth DCing that med and not continuing to add on, because polypharmacy is just so common. And with that, that was my tour of all of the things to think about with neuropsychiatric at a high level. Those are my references. This is actually the TBI Echo. It's an important enough topic that that's why we spend twice a month talking about TBI behavioral health issues, because it's dense, and things are nuanced when they come up.